Okay, good morning everybody. Welcome to the Clinical Guidelines Symposium. I'm assuming that the people who are sitting up the back are doing so because they want to have a quick nap. If you're not planning on having a quick nap, could you come down a little bit closer, because it means that we can see who's in the room rather than get a bit of a ghosty sense of who's up there. Okay, thanks very much. I'm the chair of the symposium this morning, and I'm very pleased to introduce three very valued colleagues with whom I've been working for the last at least 3 years with Suzanne and over 20 years with the other two. So we're still working together, and we must have something going for us. So I'm Karen Grimmer. I'm just recently resigned from my position at University of South Australia as a Professor of Allied Health. Suzanne Bernhardsen from Sweden, and she's a guideline developer. Janine Dizon from the Philippines, and now working in Australia as Senior Research Fellow at the University of South Australia, and Professor Quinette Lowe, who's the Professor of Physiotherapy at Stellenbosch University. We have great pleasure today to talk to you about the guideline work that we've been doing for some time. We're wanting to present to you an international view of guideline activity. So Janine and Quinette and I will be presenting work that we have done that has been funded by the SAGE project here in South Africa. So that's the South African Guidelines Excellence Project. Janine will also be talking about work that she has done in the Philippines that's funded by the PALM Group, and Suzanne is going to be talking to you about work that she has done in Sweden in guideline development in one of the regions of Sweden. So the aims of this symposium, as we have interpreted it, are to share different perspectives from 4 countries regarding CPG activities, to present new ways of thinking about strategic CPG writing relevant to local context, uptake and implementation. And we're going to discuss barriers and enablers in using CPGs in physical therapy. So here's our map of the world. I'm going to be talking to you about what happens in Australia. Suzanne's going to be talking to you about what happens in Sweden. Janine will talk to you about what is happening in the Philippines, and Quinette will finish with what's happening here in South Africa. So just to get us started, what is a clinical practice guideline? Well, there's still quite a bit of debate around the world as to what they are, but I've pulled up 2 definitions. In 2011, the Institute of Medicine in the United States defined clinical practice guidelines as statements that include recommendations intending to optimise patient care that are informed by a systematic review of the evidence and an assessment of the benefits and harms of alternative care options. Now, more recently, Treweek, who is very involved in the Guidelines International Network, published a paper to say that clinical practice guidelines are a convenient way of packaging evidence and presenting recommendations to healthcare decision makers. Now, that definition reflects the ongoing work that's happening, particularly in the International Guidelines Network, of how best and most efficiently to synthesise evidence and present it in a way that helps users of the evidence to put it into practice. Essentially, guidelines are a way of interpreting evidence-based practice into decisions that help to inform quality healthcare and affordable, effective, efficient, timely, safe, equitable and locally relevant healthcare. And what we're going to be talking to you about today is specifically contextualising evidence so that it fits in local environments and assists clinicians, policymakers and managers to take up the evidence with minimum barriers to implementation. So what you're going to hear about in this symposium are things like de novo, CPG development and contextualising implementation strategies, adoption of existing CPGs, contextualisation of existing CPGs to local settings where recommendations remain relevant, but implementation strategies may differ because of local contexts, adaptation of CPGs to local settings where new recommendations may be required and implementation strategies will differ because of the local contexts. And then we're going to be talking to you about implementation challenges and some of the solutions that we've been developing. Now, one of the major outputs that we've had from the SAGE project here in South Africa is a deconstruction of what clinical practice guidelines actually are. So we've proposed a 3-tier model. Tier 1 is the body of evidence, and that is your defensible, transparent evidence search, critique and synthesis. And this is the basis on which all clinical practice guideline recommendations should be made. Then there's the Tier 2, which is your expert input and consultation processes. So this is where you involve local people who can give you input on evidence applicability and generalisability to local contexts. Now, guidelines can't be written by Tier 1 developers alone, and guidelines really can't be written by 2-tier people on their own. It needs to be a mix of people who can bring clinical and local relevance and expertise to the interpretation of the body of evidence. Then the final tier is the product, which is the end user guidance documents. And they're products that are tailored to local users, and they could be algorithms, decision aids, protocols, etc. We struggled in the SAGE project with looking at what actually constituted a guideline, because many guidelines that were presented to us as guidelines were actually products or Tier 3 guidance documents. They didn't sit on a body of evidence. And so we have been taking this view of what is a clinical practice guideline in these 3-tier models to give us a sense of how best we can critique existing clinical guidance documents and how we can improve their transparency and their quality in a way that will help to implement them efficiently. Now, you're going to be hearing today about the adopt, contextualise and the adapt model, or the ACA model, that we've been working with in order to flow through the evidence base through into local products that can be implemented readily. Now, we've based our work on the suitcase model, and there are 3 suitcases, and I've brought our suitcase with us. I just happened to find it at Milnerton Market, so it travels with me everywhere. The original CPG is something that can be adopted. So what we're going to be talking to you about today is not recreating the wheel, if at all possible. Find clinical guidelines that have been developed elsewhere that are of good quality. So save yourself the trouble of developing a de novo guideline unless you really have to. So we've got a three-phase approach. You can adopt a clinical practice guideline and simply transfer it from one country to another, as long as you have similar country economies, language, workforce and training, health service delivery and funding models. You can contextualise the CPG. So you can take the suitcase and you can put travel stickers on it. It's still a suitcase, but it's travelled, and it's got a few bumps and batters to it, but it fits in a more ubiquitous environment. So contextualising is the process of taking recommendations from relevant, good quality CPGs that may come from elsewhere and putting them into another setting with no change to recommendations, but with additional information to assist local uptake, so strategies. So contextualised CPGs can come into countries that may have a different language, a different workforce, different training, different resources and different communications, but where the evidence base is still relevant. And the work we've been doing with contextualised CPGs requires additional Tier 2 or expert group input, as well as potentially different Tier 3 activities like writing new algorithms or new decision-making aids that fit with local context. Finally, we have the adapted CPG. So this is a suitcase chair, and this idea came from South Africa because you're so innovative here with using things in a different way. So this suitcase will never ever be a suitcase again. It's become a chair. So an adapted CPG is where you take recommendations from an existing clinical guideline and you adapt them by layering the recommendations with an additional evidence base that may be required to put the original recommendation into local contexts. And in particular in Africa, there are great needs for adapted guidelines. And some of the work that we've been doing has been looking at things like drug therapy, for instance, where a drug may be a recommended approach in a high-income, highly developed country, but may simply not be affordable. You may not be able to keep it in a safe manner. It may not actually work in local environments. And so additional information about alternative drug therapy may be required. Now, in the instance of adapting clinical guidelines, this is where you may have changes to Tier 1, Tier 2 and Tier 3. Okay, so that's the introduction. Now, my task is to talk to you briefly about CPG activities in Australia. We have a 30-year history of CPG activities for medical questions in Australia, so the whole notion of clinical practice guidelines is very well developed and well understood. We've got an over 10-year history of allied health clinical practice guidelines, and a lot of the guidelines that are produced contain medical and allied health recommendations, so they tend to be condition-based for things like stroke or for diabetes, where you may need to go into the guideline to find specific recommendations for specific allied health disciplines. There's a widespread understanding of the recognition of the need for standardised and evidence-based guidance, and there's an increasing push, almost a push back from the compensable bodies and private insurers in Australia for CPGs to be developed that assist in cost containment and accountability. Now, the National Health and Medical Research Council, or NHMRC endorsement, used to be the standard for all Australian guidelines, but we've seen increased fragmentation over the last 10 years or so, where we have different groups of guideline developers who have developed their own way of writing guidelines and believe that they have moved beyond the need to have endorsement from NHMRC. So we have different groups like the Stroke Group in Australia that are producing amazing work, internationally recognised work that has its own approach to writing clinical practice guidelines and disseminating them and talking about resource utilisation. Now, in Australia, I think it would be fair to say that the focus is largely on the production of evidence, not necessarily its implementation. So the focus is on Tier 1 and Tier 2. What we're seeing is commissioned or routine updates of the evidence base, very little, in fact, I would say no national coordination. So we've got fragmented activities, different philosophies and procedures reproducing the evidence. Most of the recognised Australian CPG activity is actually updates now of existing CPGs rather than de novo development. So we've got well-recognised stroke, pain management and musculoskeletal health CPGs. There is a continuing recreation of the wheel, however, with de novo development happening in particular states of Australia, driven by government and by industry, and particularly by the insurers. And this is disappointing because it often is not preceded by a search of what clinical guidelines are available. So there's a lot of effort that I think could be better put into implementation that's put into de novo development that isn't needed. And we've got a lot of activity that's actually not well shared. So to do a search on what guidelines exist in Australia, you've got to go through grey literature, you've got to go to insurance company websites, hospital-specific websites, state government websites to get a picture of what the activity is. We had a set of documents from the National Health and Medical Research Council that were written in 1998 through to 1999 that were state-of-the-art at the time. These are currently being updated, and I believe that they're going to be in an internet, much more readily accessible form to assist guideline developers. There is concern about costs and containing resources and better resource utilisation from specific areas in government and in industry in Australia, and that's led to independent commissioning of CPG guidelines and a growth in CPG technical writers. There remains little focus on implementation or on impact evaluation, so most effort goes into the production of the document rather than does it actually make a difference. There are still tensions between expert input and evidence-based interpretation. I've worked as a methodologist on many guidelines and led the Tier 1 resource or methodology team, and I have needed to sharpen my people management skills because often you'll have experts who will sit at the table and will be at loggerheads with the methodologists because they simply don't believe in the evidence. So it's quite a tricky thing to have to negotiate. And there's minimum focus on the Tier 3 products. So in Australia, we see a huge amount of focus on Tier 1. We really are very good at identifying down to the very last nitty-gritty study of a particular search. We do have a large focus on Tier 2 or expert consultation, but the two may not be well meshed. And we have very little focus on Tier 3 products. So a lot of our guidelines are developed as massive documents, 400 or 500 pages of document which are loaded up on the internet now, but with variable focus on the how to implement it and the decision-making processes into practice. So I'd like to hand over to my colleague Suzanne Bernhardsen, who will tell you about her work in Sweden.
Thank you, Karen, and good morning, everyone. I am a primary care physiotherapist working for one of the county councils, Region Västra Götaland in Sweden. I've been involved in guideline development and implementation for the past 7 years, and I will share the Swedish perspective, or a Swedish perspective, on guideline development and implementation. So whenever I talk about physiotherapy in Sweden, I can't resist showing this picture. Most of you may not know that today's physiotherapy has its roots in Sweden. This is a picture from the world's first physiotherapy school, which was founded in Stockholm in 1813. And as you can see, well, there are a lot to say about that picture, gender, etc. But we won't get into that discussion right now. Physiotherapy in Sweden then, as a profession, emerged in the early 1800s and was granted academic status in 1977. Today we have over 400 PhDs and we have over 1,100 specialists in different areas. We have a great deal of autonomy, especially in primary care, and direct access was introduced in 1993, which means that no doctor's referral is needed to see a physiotherapist, which of course create high demands on the individual physiotherapist to correctly and adequately assess, treat, and evaluate what they're doing, which in turn emphasizes the need for guidelines as a decision support. So guidelines in Sweden are available nationally, regionally, and locally. Nationally, we first of all have the National Board of Health and Welfare. They produce a vast amount of guidelines, but they are not clinical practice guidelines. The guidelines that are produced in this context are multidisciplinary and they are aimed at the health authority decision makers and provides guidance and direction as to how to allocate resources and how to prioritize resources. Very little is mentioned about physiotherapy in these guidelines, and certainly not any specifics as to different treatments. Our National Association of Physiotherapists is a very small organization in comparison to many other countries and don't produce any guidelines themselves. They do provide some methodological support and coordinate some guideline work in the country, and they provide a place for them to be published on their website. The few that are published, there are just like a dozen or so, and with one exception, they're not primary care relevant or primary care specific. So not a lot available for primary care physiotherapists. At the local level, some guidelines are produced, but they are really more administrative in scope, providing guidance as to local routines and care pathways for the patient. There are a number of factors that are important prerequisites or facilitators or enablers for guideline use, and one of them quite obviously, is the availability of guidelines, which, as I was just saying, there aren't really very many guidelines that are specific and relevant for physiotherapists in Sweden. So the guidelines have to be available. Another important prerequisite is attitudes, what you think about guidelines, if you consider them important, if you consider them useful in your practice. You, of course, have to be aware of guidelines. You have to know where to find them, how to find them, and you have to have easy access to them. Those are all important prerequisites for using and adhering to guidelines. Now, when we started our guideline work in our county council about 7 years ago, we began by assessing these prerequisites in a survey that we conducted in the county council. And we found among the almost 300 primary care physiotherapists that responded that attitudes were extremely positive. More than 95% of the respondents considered guidelines to be important and useful. However, when we looked at the other prerequisites, the picture was not as bright. Like if you look at this chart, the green bars shows that only a third answered yes to being aware that guidelines existed, 13% to knowing where to find guidelines, and as little as 9% said that they had easy access to guidelines. With the blue bars, another 50 to 60% answered partially to those questions. But a lot of the physiotherapists did not perceive that they had knowledge and access to guidelines. And when we looked at the guideline use, less than half reported that they use guidelines frequently, another 40% sometimes, and 12% rarely. So there was definitely a need to address those barriers. We did that in this survey, which was part of my PhD work, and more can be read about that if somebody's interested in this paper. We also assessed the barriers, and by far the largest perceived barrier is lack of time, which was reported by 2/3 of the respondents. And this is in line with pretty much all other studies that have assessed this in other countries as well. So we all complain about lack of time in our clinical day-to-day work. Other important barriers were not knowing where to find guidelines, that they are too general and not enough specific, that they take too long to read, and that there aren't enough guidelines. So I'm going to talk a bit about how we go about with the development of our guidelines in our county council. This was a work that began in 2010 when we perceived this lack of evidence-based guidelines to support our decision-making. And a quality improvement project was initiated at the regional level by unit and physiotherapy managers who perceived that there was quite a wide variation among the different units in how we treated our patients. So the initiative was sort of a top-down perspective, but also combined with a bottom-up perspective in that we were some clinicians, and I was one of them, that perceived this lack of and a need for guidelines to support our decision-making. Another important piece of background, of course, for our guideline development work, as for most guideline development work, is the extremely rapid growth that we've seen in physiotherapy research, where the red curve here shows that back in the past couple of decades, back in 1990, there were less than 4,000 randomized controlled trials. In 2013, when this chart was made, we were up to 24,000. And I like to go into Pedro and have a check, and we're approaching 30,000 now. So that's all wonderful, the PT researchers. So good on all of you. I'm sure there's some people in here that have contributed to these numbers. And this, but the downside of this is that it creates the great need for how to summarize and synthesize all these research and get it out into practice. And just to show you, I'm talking about our county council region, Västra Götaland, which is positioned in the western area of Sweden. And Sweden is, of course, sits on top of Europe, the same size of Italy or California, but with 9 million people. In region Västra Götaland, we provide healthcare services to 1.7 million people, which is a fifth of our population. So when we initiated this project, we put together a guideline development team comprised of 5 physiotherapists. We collaborate with a reference group of managers from the whole region. And when we began the work, we used a systematic approach with 5 partially parallel processes. First of all, we needed to survey and do a needs analysis, which was the determinants assessment that I just talked about. At the same time, we developed a strategy for how we were to develop the guidelines, develop routines and templates for what the guidelines would look like. We searched and appraised existing Swedish language guidelines, and the few that we found were either quite old or they didn't reach up to high quality when we appraised them. So we decided to embark on our own de novo guideline development. We also looked at all the outcome measures that existed and decided to try to narrow that down a little bit, since there's so many, and we used a wide variety of different outcome measures as well. Our development work was based on 3 things. First of all, our association's handbook on how to develop guidelines, the AGREE instrument, which is a 23-item quality appraisal instrument to assess the quality of guidelines and what goes into them. And we also used a guideline development model by Dutch researchers Berger et al. And this shows this model, and I'm not going to talk through it in any detail, but the first 2 steps are the preparatory phases, where we do the needs analysis, which we did in the survey, and also to create the good conditions for a good guideline product, put together the working group and do the project planning, etc. In step 3 is the actual development of the guidelines, which I'll get back to in my next slide. Steps 4 and 5 involves subjecting the guideline to external review, and we do that by peers. We pilot test it among our colleagues, and we also subject it to external experts and get a lot of feedback, and then revise, and we revise in a number of versions. Step 6 is about the design of the guideline, which is actually quite important too, to make it readable and usable. And then in step 7, evaluation and revision, we monitor the use of our guidelines by looking at, for example, web statistics where they're published, and we collect feedback from the users, and we revise, and we have a strategy for updating and revising the guidelines. So that's step 3, the actual development process of the guidelines is a very systematic process that resembles what we do when we do systematic reviews. So we develop our search strategy, our PICO, we search, we select, and we appraise the underpinning evidence. We do try to choose systematic reviews as the underpinning evidence, since that's at the top of the hierarchy. For some conditions, we need to go further down the hierarchy, so we look at individual studies. So we extract and we summarize and we appraise the total body of evidence using GRADE. And we write recommendations and submit it to external review, as I said. So the key words here are systematicity and transparency in the guideline work. The format, to address the barrier that the guidelines are typically perceived to be very long. So these are all going to be in Swedish, but I think we might have some Swedish people in the audience that can understand. Our guidelines are 4 to 5 pages long, and they begin with a front page summary of the recommendations in order of strength of evidence and with clear links to the supporting evidence. We then follow up with brief narrative summaries of each intervention, also in order of strength of evidence. We provide detailed references in the odd case that somebody might want to go and dig into and learn more. And then we have some appendices, notably a whole summary where we translate from English to Swedish the underpinning studies. We attach recommended outcome measures. This is the patient-specific functional scale. And the patient information sheet that goes along with the guideline, which mirrors the recommendations in the guideline so that the patients also get a feel for the different interventions. So some reflections from my years of guideline work is that it's very important that the guidelines have a clear scientific base, that they are brief, to the point, and relevant. Not to use overly scientific language. We try to avoid too much statistics and confidence intervals, as we found that they scare off your general practitioner. They need to be attractively packaged in terms of format, and they need to be easily accessible, of course. They need to be tested and revised in a number of versions. And of course, systematic development needs to be followed by systematic implementation, since guidelines do not implement themselves. So, a few words about how we do the implementation work in our county council. Implementation means different things to different people, and we like to divide it, first of all, in central implementation, which is driven by managers and is more of a top-down perspective, or a push, and the other end of it is a local implementation, which means more uptake and integration into the daily practice and is driven by the clinicians. So we've used both approaches in our work. In implementation research, we also talk a lot about passive versus active implementation strategies. And they can also actually be illustrated on a continuum where the most passive form of implementation is diffusion, going through dissemination to implementation, where diffusion is really more just a spread, an unplanned, untargeted spread of a new method or a new guideline, through dissemination, which is more planned and more targeted to a specific context, to implementation, which is more about the integration of the guideline into daily practice. And in some simpler words by Trisha Greenhalgh, you can equivalate diffusion with letting it happen, disseminating, you help it happen, and implementation, you make it happen. There are many different implementation strategies, and there's a lot of implementation research done to test all those different strategies. And this is a summary of actually Cochrane reviews. So in the source column to the right, there are all different Cochrane reviews that have summarized different implementation strategies. And as you can see in the middle column, the effect size is quite low of all of these different strategies, somewhere between 4 and 12%. Doesn't sound like a lot, but this is all measured at the practitioner level, not at the patient level. So it's behavior change of the clinicians that have been subjected to this implementation strategy. The two strategies that we've used in our guideline implementation work are educational meetings and tailored interventions. And the tailored implementation, when we do that, we tailored the identified determinants that we found were barriers or facilitators to specific intervention components. I don't need you to read all this, I'll just highlight an example. For example, one of the largest barriers were limited access to guidelines, which we addressed by creating a dedicated website where we put all our guidelines. And also, in terms of the guideline characteristics themselves, they were found to be too general and too long, so we made sure that they were brief and specific. Some of the central implementation activities that we do is to use this tailored strategy comprising several components, and it's also informed by both theory and evidence. And these are the components that we used in our implementation work. Distribution of the guidelines themselves, educational meetings in the form of seminars, which we went out and held in many different locations, and included group discussions. Of course, the creation and publication on the website, and some other components that we used. And you can read more about this. This strategy and these components were evaluated in a study that was also part of my PhD work. And this is what the website looks like. It's technically not the most modern look, but these are two different sites. And to the left, we see all the different guidelines that we produced so far. We're up to 23. Each guideline takes us between 6 and 12 months. In the rare case, it's gone over a year. And to the right is an example, lateral epicondylalgia, where you see the brief summary in the central column, and to the right are all the attachments, the appendices, patient information, etc. So that was a central. We also do some local implementation activities that are really up to the individual units and up to the individual unit managers or sometimes we have a colleague, a clinician who's acting as sort of a champion and takes guidelines to their hearts and act as a local guideline person. So the activities that are done is that guidelines are introduced to new hires and to students. They're discussed at different kinds of staff meetings and at internal continual professional development. And the one item that's the most popular among our colleagues is the patient information leaflet. They're all posted in the waiting rooms at the clinics. So some conclusions about the guideline implementation that we do is that you're talking about changing behavior to get people to use guidelines, and it's not something that's done overnight. It takes a lot of time and requires a lot of perseverance and sustainability, regular, repeated educational sessions. It's important to minimize barriers and to build on the facilitators. And it's important to create awareness of the methodology because that increases the credibility and the use of the guideline. When we talk to our clinician colleagues, we show them the methodology that I just showed you, but in some more detail and a bit slower. Their jaws drop and they say, "Wow, that's what you're doing all of that," and that really creates even more positive attitudes and make them use the guidelines more. Stakeholder buy-in is very important from the users, the clinicians, from the patients, from management at all levels, and to have engaged clinicians at the local level. So with that, I thank you for your attention. And leave the microphone to Janine.
To put this down a bit lower, and I hope everyone can see me. Okay, so today I'm going to present to you our work on contextualizing and implementing clinical practice guidelines in the Philippines. Our project are the following. So we first contextualized the guidelines, and then we had to do an audit project on stroke practices, stroke rehabilitation practices, and then we implemented the contextualization guidelines. And I'd like to acknowledge the team who were part of this project. So it was led by the Philippine Academy of Rehabilitation Medicine, the University of Santo Tomas in the Philippines, and the International Center for Allied Health Evidence in Australia. So the Philippines is one of the countries in the Southeast Asian region, and as you can see, it is composed of several islands. And in fact, the Philippines has 7,100 islands on high tide. Yes. But during low tide, it's 7,107. So we have 7 islands popping out every now and then. Okay, but the importance of that is knowing the difficulties of how you get health services in different parts of the country, and that was really very challenging for us. And so, yes, I told you the Philippines is a lower middle income country consisting of those number of islands, and Filipinos, well, from the last count that we know, we are over 100 million. And one of the really challenging issues that we are faced with in health is that we have very variable access to healthcare, from very well-resourced and world-class tertiary hospitals to community health centers, which are sometimes just staffed by one health professional or nurse. And then private insurance is very limited. The government doesn't have enough funds to cover for the health expenditure of its people. And there are significant patient out-of-pocket expenses, which now imposes a big problem in terms of providing health care to the people. In 2009, the government launched a continuing quality improvement program with very limited funding, but was directed to the development of de novo clinical practice guidelines, because that is what's happening internationally. But sadly, there were no funds for dissemination or implementation at all. So, given that scenario, we thought we were faced with a very big challenge in front of us because we didn't know where to start, we didn't know what to do, we didn't have the capacity to develop clinical practice guidelines in the true sense of the word. We had very limited funds, and we also have limited time to do all of this work. And so we ended up just scratching our heads. However, okay, we thought that we have to do something good, we have to think of something bright in order to address the challenges that we were faced with. So we had a brainstorming meeting. We were waiting for the light bulb moment to come, and unfortunately, it didn't come that soon. So we were all caught in the dark for some time. But we thought we first start with assessing what we had. So we know that we have national leaders in the field of evidence-based practice and rehabilitation because we have trained individuals in these areas. And then we have a very long-standing and strong links with an international methodology group, which is the International Center for Allied Health Evidence in South Australia. And there was a lot of goodwill among the Filipino health professionals involved in stroke rehabilitation in the Philippines. And they were very happy to extend their time and efforts so that we can have a more directed approach in coming up with guidelines that would fit our local context. Okay, and so the first plan was to develop the NOVA guidelines because we were mandated by the government to do that, and then internationally that is what most countries are actually doing. But when we were having our meetings and we had our reflections on what we have and what our challenges were, we know that we have limited time and resources, and thus we know we have to use them wisely. There was no point in wasting any resource at all. And then in our initial scope of the literature, we found that there are so many guidelines in stroke that have been published already. And then we said that if that's the case, then we have to focus on the more important part of clinical practice guideline, which is implementation. And so we thought, okay, we'll have to discard Plan 1 because we don't want to develop new guidelines if there are so many available there, and we don't want to recreate the wheel. Our second plan was to adapt stroke guidelines because we found that there are frameworks, particularly the ADAPT framework, which provides guidance on how to adapt guidelines. Okay, so the framework suggests that you choose one guideline which is most relevant to you and then adapt them to your needs. However, we did not find one single clinical practice guideline that addressed all our questions and our need for guidance. And so there were several guidelines that we could use, but there isn't one that would readily fit our need. And then there was also very limited guidance on how to adapt the guidelines for developing countries with different resources and resource constraints. So sadly, we had to discard Plan 2 again. Okay. All right, so the third plan, which is the last, and hopefully it's really what we needed and what's going to work, and you will know more later. We reflected again and thought that guidelines are there for to deliver best patient care, to make use of resources in a more efficient manner, and so that we can improve healthcare services. And at the end of the day, everything goes back to evidence-based practice. And so we know that evidence-based practice is composed of three important components, which are research evidence, clinical expertise, and patient values. And then more importantly, especially in the last probably 5 to 10 years, there has been a focus on underpinning evidence-based practice principles with context, because at the end of the day, it would only work if it fits the local context. And especially because there are uncertainties in clinical practice that you cannot always find the best answer to address a specific condition. And so we use the evidence-informed practice model, which is recognizing uncertainty in evidence-based decision-making within the local context. However, okay, people have been talking about context, but we needed to understand first what is context. So by definition, context means that these are the circumstances that form the setting for an event, statement, or idea in the terms of which it can be fully understood. So which means it relates to the background, to the environment, to the framework, setting, or situation surrounding an event or occurrence. And then we are now finding some light at the end of the tunnel, because we now realize that we need to make use of existing clinical practice guidelines that are available, which are recent and good quality. And the evidence that come from these guidelines were actually relevant to what we needed. So for instance, let's say we're looking at stroke guidelines, and stroke is stroke anywhere in the world. So the way it's diagnosed, clinical manifestation of stroke would not be different at all. The difference is how care could be delivered to stroke patients depending on which setting they are coming from and who are the health professionals who can deliver that care to the patients. And so we thought that we don't need to change the evidence, but we need to address issues to be able to implement the evidence, which are health service delivery issues. And thus, we now came up with the contextualization approach of clinical practice guidelines. Okay, to tell you a bit more about it, we had to map the patient journey. That was the key to it all. We needed to first understand what is the usual care pathway for a usual stroke patient in the Philippines. And then, in each point of the pathway, we identified the points where we needed guidance. And we identified this as the critical decision-making points where if, let's say, for example, a referral of a stroke patient to a health specialist needs to be done, who does the referral, how is the referral going to be done, and is there somebody to refer that patient to? Okay? And so then we identified system issues, healthcare provider issues, and patient issues. And now this assisted us in identifying critical decision-making points along the usual patient pathway that required the best evidence sources. And then we searched for the relevant recent clinical practice guidelines, critically appraised them, and then extracted the recommendations for the critical decision-making points in the patient journey. Please take note again that we did not change any recommendation. Okay, we used the evidence base and we used the recommendation. And then because sometimes there was more than one guideline available to answer that question in the pathway, we amalgamated the wording of multiple recommendations for that same decision-making point. And then we endorsed existing recommendations, and then we came up with Filipino-specific context points which address the local generalizability and applicability and appropriate measures of outcome. Okay, so to give you a better explanation of what I'm talking about, I'm going to give you an example of one of the recommendations that we found from the SIGN guideline in 2010 on dysphagia assessment. So the SIGN guideline says that there is strong evidence that the water swallow test should be used as part of the screening for aspiration risk in a stroke patient. Okay, so there was no question about the evidence. Okay, there's strong recommendation that this needs to be done, and it's relevant to our local context. And I think every one of you here would say that it's also relevant in your practice. And so we had a statement in our guidelines saying that PARM, which is the Philippine Academy of Rehabilitation Medicine, strongly endorses the water swallow test, and it should be part of the screening for aspiration risk in stroke patients. So what we did was to come up with a table of context points where you could find in the first column are our local context considerations. Now, those context considerations were based from our setting. Some of them may be similar to yours, some of them may be different, okay, because it's local context based. And then the next column presents the minimum standard of care to be able to implement the recommendation in the most basic setting of the community. The third column is for additional standard care of practice. So let's say, for instance, it's in a tertiary hospital, a world-class tertiary hospital, and therefore there are more available resources that could be used or that could be given to patients. So for example, if we talk about the water swallow test that needs to be done for screening, the context consideration that we first had to think about was the diagnostic tool. So what is the diagnostic test that we need to use? At the minimum standard of care, the water swallow test, which is the 3-ounce test, would be very useful. Okay? It's very easy to do, and if we train the health professionals to do it, then they could do it. However, if, let's say, the patient is in a metropolitan hospital with access to a barium swallow test or a video fluoroscopy modified barium swallow test, then they could provide that to the patients. We looked at equipment. So if we were to do the basic water swallow test, all we needed was water. And that's it. Okay? If it was in a tertiary hospital, then they have equipment, then that's fine, they can use that. And then again, you have to look back at the context in the country where there's very minimal support from government to cover the health expenditure of the people. So if people have to pay out of pocket for this, then they have a choice of what they would want to receive as a form of assessment or a treatment. And the list of context consideration can go on and on depending on what is relevant to the setting. Does that make sense to everyone? Okay, then when we finished with all of the recommendations that map the critical decision-making points in the pathway, we now identified the recommendations with the strongest evidence which needed to be implemented. And so we came up with a list of key recommendations from the PARM stroke guidelines, and we developed a protocol, and we implemented the protocol in 3 rehabilitation training hospitals in Manila in the Philippines. We also had a CPD session with the health professionals involved, so we had a 2-day training in guidelines and orientation to the protocol that we plan to implement. We also developed end-user guidance documents in the form of checklists, algorithms, forms that were supposed to guide the health professionals in implementing the key recommendations that we have given to them. We also did a qualitative research and interviewed health professionals who were involved in the implementation of the guidelines. And I'm going to report now on the subset, which is the interview of the physiotherapists who were part of the implementation of the guidelines. So when we asked them about their perspectives about the guidelines, they said that the guidelines served as a guide for practice, obviously. Okay? They thought that the guideline was helpful, easy to understand, and guided them in the care of their patients. They also perceived the guidelines as a way to improve clinical practice because it resulted in improving the patient outcomes. It also facilitated collaborative activities because it did not just involve the doctors or the physios, but there were also OTs, there were also nurses who were part of the implementation of the guidelines. And at the end, they said that it's really challenging to implement guidelines, which is actually a known fact, because there could be inconsistencies of implementation, and then because it involves changes in behavior, okay? But that was good to highlight too, because we know that they know there are ways of how we can improve the implementation based on what they reported as challenges. So the challenges that they said were the following. Current practice and dominating habits, which again goes back to usual practice, and is very challenging when we are implementing guidelines, especially with newer models of care, or let's say new interventions or new forms of assessment, which they were not used to. And of course, there would be some resistance to some of the members of the rehabilitation team. Then also there is the issue of hierarchy. So the Philippines is a very hierarchical, we have a very hierarchical culture. And so to be able to get things going, we need to know who are the right persons to talk to. So if we had to go through the department head or the hospital head and then the consultant of the department, we had to do that. But that was identified as one of the challenges. And then as much as we tried to address setting, there were also some issues about the specific setting of the hospital and the available resources. So that's why when we did the training again to them, we highlighted that they have to know exactly how to assess their local context, because that would be one of the key strategies in implementing the guidelines in their local context. We were happy to hear that there were facilitators or enablers in implementing the guidelines, and we used this in the next phases of the project. So the orientation given to them about the guidelines, about their participation was helpful. The reminders, the posters, and flowcharts, the documents were helpful as well. And the support given from the professional organization and the participants involved were very helpful. And the structure of the guidelines, so the context points, the table that I showed you a while ago with the context points and how we delivered it to them was very much appreciated. And thus, moving forward, the strategies to improve guidelines in physiotherapy were identified. And these are the involvement of the professional organizations. And they thought that professional organizations should endorse the use of the guidelines. And then because of the hierarchical culture, we have to include the top-level players. And then we encourage people to build trust in the guidelines, because if we have enough evidence to say that these guidelines are relevant to our context, it works, then people would consider implementing it more. And then we identified a procedure where it's not a procedure, it's more of a multidisciplinary involvement, where we don't just focus with one group of health professionals, it's involving the whole team. And then some of the physios suggested that stories of change might help, because this is a novel idea, and if we as clinicians love hearing success stories, and if we share the success story, it might motivate them more to implement the guidelines. And this is my last slide, just to keep you on track of what the outcomes and outputs were from this project. So we have 8 papers coming out from these projects. 5 have been published, and we're happy to share them with you if you want. We have been presenting in conferences, doing workshops, teaching allied health professionals, physios, and whoever's interested in the methods that we've been doing. On the national level, we have now 5 contextualized guidelines, and these are on stroke, low back pain, hip osteoarthritis, neck pain, and shoulder pain, which are all indexed in Dynamed and EBSCOhost. We have been doing stroke and low back pain caravans, so we brought our training to key cities in the Philippines. We now have updated the stroke and low back pain guidelines. We also found opportunities to educate doctors, physiotherapy clinicians, masters, and other undergraduate students. And then more importantly, I think the impact of this on the national level is the inclusion of inpatient rehabilitation sessions in the government insurance, which means that the patients would not have to pay. So if they could have at least 3 or 5 sessions of inpatient rehabilitation, that would really help them. And in the international level, our contextualization methods have been endorsed by the International Society of Physical Rehabilitation Medicine. And this approach has also been applied in South Africa, and our colleague Quinette is going to present it in the next session. And we are also testing the methods now in Australia, because it's not an issue of developing versus developed countries. It's more an issue of what is your context, and your awareness and assessment of your context will lead you to knowing what are the best implementation strategies. So thank you very much. It's maraming salamat po in Tagalog.
Okay, so I don't know if people feel like just getting up for a minute and stretching while I get this ready. Yeah, it's a long sit. Okay, thank you. It's quite a long session. nearing the end now. So good afternoon, everyone. I will be talking about the state of play in South Africa, and it will be slightly different to what we have heard from our colleagues in Sweden, well, in Australia, Sweden, as well as even in the Philippines. So in terms of the background, just to give you a little bit of insight into the burden of the disease and where we are as a nation. Some of you may know that we are now well into our democratic era, but we are experiencing a significant transition in health. And this is mainly because of the shift from communicable to non-communicable diseases, as well as trauma, which plays a major part in terms of our burden of disease. And in terms of our constitution, access to healthcare is very, very is a right in South Africa, but unfortunately, many people still don't have access to basic care, and even less people have access to rehabilitation. So in the past, and even up to today, there has been very little focus on the importance of rehabilitation, and particularly the importance of rehabilitation that we play within the major diseases that's facing our society. And our government priorities have really just been on saving lives, on survival. But because many of these communicable diseases, such as HIV, TB, are now actually classified as chronic diseases, and these people are now able, because of new generation drugs, to pursue a much longer lifespan, the importance of quality of life is now recognized more and more. So anecdotally, we hope and we think that there is now an increasing demand for allied health services and rehabilitation, but unfortunately we are still faced with some of the challenges, such as the insufficient workforce as well as lack of resources. And obviously, in our context, we currently really have no committed, directed strategy towards evidence-based care in rehab. So just for international visitors, to say that South Africa is experiencing a quadruple burden of disease. I always find that some of my international colleagues don't understand that term. That means we have at least 4 major causes of death, which is very different for a government to deal with compared to just dealing with one major cause of death. This is putting a significant strain on the healthcare resources and unfortunately putting rehab further lower down the list of priorities in terms of resource allocation. And as we're talking about rehab and allied health, the most common causes of disability in South Africa, as you can see, are actually linked to the major diseases that face our population. And this includes HIV, it also includes mental disorders. But interestingly, I think from physio point of view, you can see how low back and neck pain has moved up the ranking in 2015 in terms of the causes, major cause, in terms of being a major cause of disability. So I put in the slide just to show, or perhaps just sort of conceptualize where we are in terms of rehab in South Africa, and this actually is moving obviously beyond just physiotherapy, and this is not necessarily based on research, but it is just my understanding as a researcher in terms of sort of our evolution here. And if we can just start at the bottom there in terms of the rehab needs, is that we really don't have a good idea of a quantitative idea of what the rehab needs are within South Africa. And this perhaps slightly better in urban areas, but semi-urban and rural, as well as remote areas, we really don't have an idea of what is needed. And obviously, some of these issues are linked to the fact that, besides the fact that we have very little resources to deliver care or rehabilitation to the population or to society, we also have significantly less research funding in order to develop large-scale databases, in order to establish the needs, in order to understand our context much better. This actually has major implications, as just this week our national health insurance plans have been gazetted and is now open for public comment. And we have been asked to give input on our needs in rehab. And unfortunately, we don't know this. Linked to that, we really don't know then, if we don't know how many people need us, we don't know how many people we should tell government to give us as part of this new national health insurance system. So this is a real challenge for us. There's a real opportunity for us now to include rehab into the NHI. I think the door is open now, but unfortunately, we have to provide quantitative information as well as qualitative information to our policymakers. And then we have not really been integrated well into the healthcare systems. And here I'm particularly referring to the public healthcare system, which caters for more than 80% of our population. Yesterday I said that we have less than 1,000 physios looking after 40 million people in South Africa. So the access is poor within the public system. We are not integrated into the systems per se, and we need to advocate for that. And unfortunately, linked to large-scale databases, we also don't have large-scale outcome measurement of all the patients we have seen and probably helped over the years. So these are really very, very important information and databases that we will need to collaboratively develop between universities as well as other important stakeholders. And probably now we are also faced with this international pressure to deliver care or rehabilitation in an evidence-based approach. So the reason why I showed you this slide is that I'm going to be talking to you about this top-level evidence-based care CPG approach that is critical and important for us. But there are so many of the other prerequisites that's really not in place and is really influencing our ability to deliver evidence-based care. So we have started as part of the South African Guidelines Excellence Project, of which we were very grateful to have 2 physiotherapists as co-investigators. It was myself and Professor Grimmer. And we have convinced our colleagues who are medical professionals to conduct a sub-study on rehabilitation. Because after one of the main goals was to map all the guideline activities at primary care. And unfortunately, they were all biased to medical guidelines. Rehab was not included. None of the national guidelines contained any information or recommendation on rehab or for rehab. And therefore, we felt that it was important for us to at least make a start and conduct a sub-study and find out who are developing guidelines in South Africa in any field of rehab, allied health, which included OT, physiotherapy, speech pathology, even podiatry. And we also included other important stakeholders, for example, from 4 provinces who are the policymakers at the Provincial Department of Health. We interviewed them. We have also interviewed the important rehab stakeholders at the National Department of Health to find out where they are, what they are doing, and what their plans are to move evidence-based practice forward in rehab in South Africa. And this sub-study, we have just used the CORIC framework for quality standards. And the sampling framework was obviously very interesting in terms of to make sure that we actually speak and engage with the most relevant stakeholders, because if nothing is really happening, we didn't know where to start. So we actually have done a special sort of sub-study of the sub-study just to try and establish the sampling framework. And we have published this as a separate study. If you are interested, unfortunately I didn't put the ref, but if you're interested, you can come and ask us later. And we have considered nationally different provinces. We have included 4 based on the factors that we have considered. And these are all of the factors that we have also taken into consideration. This is all the National Department of Health, Provincial Department of Health, the district, the sub-district, the community healthcare workers, all the professional bodies, all of the networks that's available in urban and rural areas, the professional associations. We also talk to funders, we also talk to private practitioners, and we talk to university counterparts as researchers and potential developers of guidelines, as well as other consultants. So, in summary, I think the overarching issue remains in terms of we really don't know what, who, and how. We didn't know what we should develop. Given our significant burden of disease, where do we start? Also, in some instances, people didn't, the stakeholders that we engage with didn't have a clear idea or uniform idea about what a clinical practice guideline is. So we really have to start at the bottom up to first have a common understanding for South Africa in order for us to move forward. And as I said, in terms of prioritizing, that in itself is a challenge that cannot still simply be done by the developers, but must be done with political stakeholders. And in terms of whom, that was another question, because the National Department of Health told us that they are there for policy formulation. The Provincial Department of Health told us that they are there for implementation of the national policies. And the professional society told us we just look after our members. And so we really still don't have a clear idea as to who must take responsibility for national guidelines in rehab, and who will be and should be the important stakeholders. And thirdly, we are still baffled with how, and through our linkages here with Professor Grimmer, Janine, and others, we have some ideas now of how we can move forward with feasible and cost-effective development methods, which is maybe more appropriate for low and middle income setting. But obviously, we cannot stop there. Implementation will be another big challenge. So, this slide speaks to some of the work again that we have done as part of the South African Guidelines Excellence Project, and this really represents the map of all of the guideline activity that we have found, not necessarily in rehab, but particularly pertaining to primary care in South Africa. So just again referring to the 3 tiers, as you remember, the first tier was the evidence-based, the second tier was the consultation, which we thought was quite good, and again, perhaps not a good match between those. And what we have found is that a lot of voluntary efforts of people who have provided input, of people who were willing to participate and be a stakeholder, and who are really dedicated to move rehab forward. And then in terms of tier 3, we have really showed as South Africans some innovation in developing tier 3 documents. I think potentially we can actually become the leaders. For example, the PAC guideline, which was developed for nurses, has been published in the Lancet as a major implementation study, has been taken up by in Brazil. And this is a key vehicle to move rehabilitation and to improve improve the uptake of evidence-based guidelines at primary care level. So we have been really good at tier 2 and 3, but we have been really bad at collating and synthesizing the evidence. And in fact, in many instances of the guidelines, of all of these guidelines that we have reviewed, there was actually no linkage to the evidence base. So we will have to step up on that. in order to improve confidence in using of the clinical practice guidelines. We have also asked particularly to the rehab professionals about the barriers and facilitators, and this slide just summarizes that. And on the left in red, all of the red flags, and these relate to the context and obviously the staff shortages, the transitioning healthcare system, which is difficult to cope with because in terms of resources, it's just demanding so much more. And some of you may know that we've just been downgraded our economic status to junk status. So this is very challenging for us. The social factors are significantly more problematic and challenging within our context than many of the areas or countries where you come from, as well as the legalities related to that. Many of the recommendations cannot be put through the government in terms of a National Department of Health policy, because once they do that, they become legally obliged to deliver on that. And if they don't have the resources to do that, that could have very serious legal implications. And in terms of leadership and mentoring, obviously that is another challenge for us. We are very poorly represented at all levels, and we need to continue to advocate. There's a lot of bureaucracy to get information and change policies and systems. And also, we don't really have good political advocates. We are good doing our research, at the university, but we are not really good at selling that to influential stakeholders. And in terms of support, we have very little. We have a few teams at universities who are doing work with postgraduate students, but this is probably not enough to make a national impact. And so we will need to do more in terms of developing skills for implementation, monitoring, as well as development, implementation, and monitoring. But in terms of the rehab workers, we have found a few plus points, and this is really that there has been very good interdisciplinary cohesion among rehab workers. And this is, for example, the Rural Network, which is a multidisciplinary network of people working, of rehab workers working in the rural areas, which provides an excellent base for which we can translate evidence-based guidelines into practice. The other facilitator, I find it could also be a barrier, is the new National Health Insurance minimum standards that needs to be developed. We can use that opportunity to move away from expert opinion and perhaps try and move evidence-based recommendations into this minimum standards of framework that is currently needed and on the table. And then, again, I said that there was very good networks, not only within professions, but also between stakeholders, such as universities. So, the implications for us here is that still some of our barriers outweigh our facilitators. Rehab professionals, traditionally we are very practical people. We like to help people at an individual basis. We work one-on-one, but we need to become change agents. We need to become more robust in that field in order to impact at a societal level. We need, for our context, to really consider the social factors. In many of the rural areas, people don't have access to running water. They have children. The children, primary school children, are looking after their young mother with HIV who had a stroke. So these social determinants must be built into our recommendations. I talked about the economic factors and also other context-specific factors which are currently known and unknown to us must be explored, and this can be done by perhaps increasing research funding. So I want to also say that one positive point is that last year we have published our first National Disability and Rehabilitation Framework, which was steered and published by the National Department of Health. This, for me, is a very positive spin-off. It has now been accepted by all provinces, but to implement this framework, all of us will need to make sure that it is implemented. Because while it's out there, it's not going to implement ourselves. And the physios, OTs, and other rehab professionals must make sure that we hold government accountable for the goals that they have set out, and make sure that whatever we do are actually linked to these 5 core goals. And this is to integrate rehab services into the priority disease burdens that faces our society. And if we start and prioritize those, I think we will get some people to listen to us. We will need to develop appropriate and efficient referral systems. And important for rehab, and this is so great that this goal has been included. I've just highlighted the ones that I feel are the 2 in red that's most important, is to foster intersectoral collaboration to address the social determinants. Because within our context, we cannot just move or work within the Department of Health. In terms of grants, in terms of support, in terms of, we need to really ensure that the people become economically viable, employable. So other sectors, such as the Department of Labor, many people can't access care because of transport. So the Department of Transport, we will need intersectoral integration in order to facilitate societal participation. And then, of course, there's the issue of accessibility and just general awareness of rehab and improvement in infrastructure. So we are very, very positive about alternative approaches that is more cost-effective, feasible, and time-efficient for our context. And my colleagues have already explored many of these, the positive spin-offs of using alternative approaches. And in summary, I just want to say that the way forward, I think, we will need to be proactive. We will need to, in some ways, even be opportunistic when there is an opportunity to tap into. In some way, I find that we have really, although we have really adopted the medical model, not only in our training, although we do say we are applying the biopsychosocial model, but we also adopted the medical model for evidence, and that's why we now have 30,000 randomized controlled trials. And it's becoming very difficult if you don't show a randomized controlled trial to policymakers. And there are maybe other forms of evidence which are so important for rehab, because we do individual tailored approaches. So studies like N=1 and very large outcome data of databases could have been such very good evidence. But unfortunately, in some way, fortunately in many ways, unfortunately in some way, the policymakers have also now been educated about just randomized control trials. And sometimes that is very difficult and costly to do within our context. We need to optimize also our facilitators and pool our resources and work together to improve our chances for impact. And we need to strengthen our networks. We need a critical mass of rehab professionals that will work within this field. And finally, I think we need a new generation of leaders, away from expert opinion leaders to almost political leaders who can advocate for change. Thank you.
Okay, well, it just leaves me to wrap up. I'd like to thank Suzanne, Janine and Quinette for giving you very thorough appreciation in a very short period of time of the challenges that they have faced and in many instances met. We've also had some cogent stories from 3 very different environments, and 4th, if you like to add in the quick overview I gave you from Australia, that guideline activity can, despite the amount of effort and intellectual input that it's had, can still be very different depending on the context in which it's done. I guess our message is, please don't recreate the wheel, because there can be so much focus put into developing another look at the evidence base, and that takes it away from, well, how do we put this evidence into practice? And in reality, does it matter that you've had another 10 randomised controlled trials published in the last year? what matters is how well did you implement the information that you had last year. So we need to take a very different view, I think, of how to use the evidence and how to make it work for you in the environment that you're in. So I'd like to suggest that from this talk, you consider making implementation your focus rather than the development or the redevelopment of the evidence base. You need to consider in your environment why CPGs are needed, who will use them, and this definitely comes from the Tier 2 and Tier 3 activity, because if you produce information that can't be used in appropriate translation, that can't deal with the health literacy of the end users, if there's no belief in the value of the evidence, then all of the effort that you put into producing the evidence could go to waste. The way that Janine and Quinette in particular have dealt with the need to produce evidence efficiently has come from the typical patient pathway approach. And we found from the work that we've done, at least in those two countries, and I still need to talk to Suzanne about how she, or whether she managed this at all in this Swedish approach, is that unless your work is targeted to the patient and to the pathway that they will go on, you end up with a fragmented view of what recommendations are relevant. And they don't, and that the patient pathway actually produces an initial streamlining or a facilitator into recognising what your local barriers are to implementing and the need for the evidence. So we've heard from Suzanne about de novo CPG, or starting from scratch, but I'm not even sure they started from scratch. They used existing systematic reviews as their focus for their evidence, so they already went to synthesised evidence and collated that into their need. And I'd like to put this quote up from Petronius. I'm sure that you've seen it before, but it's about recreating the wheel and how disorganising that can be. And I think sometimes when there's money available and time available, it's easier to recreate and rewrite a clinical practice guideline than it is to face the hard truth of how do we make this work, how do we put it into practice. Now, issues with de novo CPGs, and we heard from Suzanne about this, is that they're expensive, they're time consuming, they take a lot of effort and they can be really exhausting. And the fact that you've produced 23, did you say? Do you sleep? Very often clinicians who are the ones that are left to produce the clinical practice guidelines don't have the training that they need in evidence-based practice theory, and so they stumble along and often they'll be inefficient in their use of time and resources. Most, particularly in allied health, evidence-based practice activities and clinical practice guideline activities are voluntary effort, and people run out of energy and time when they have to work really hard. So we've heard from two other countries and developing countries about an efficient approach that has been certainly trialled in the Philippines and is underway in South Africa, where we use an existing tier 1, we use an existing evidence base, we build on it, we don't re-question it, because if you think about the factors involved in evidence production and then evidence implementation, Tier 1 is the evidence production, Tier 2 is the localisation or the contextualisation of that evidence to the local environment using the local experts. So these aren't just clinicians or policymakers, they're patients, they're families, they're government officials, they're managers, they're the people that understand about the on-the-ground application of clinical practice guidelines. Now, the reality of that is that it identifies and breaks down local barriers to uptake immediately, because that's the focus of that group. Then there's the production of your end-user documents relevant to local context, and that's the products that will make a difference. So if you need to have a clinical decision-making tool or an app or a piece of A4 paper that's laminated that can go on the back of the door, that's the product. It's something that has to be oriented to local need. So I just want to leave you with a few reflections on implementation. In the developed world, as in Sweden, as in Australia, as in the UK, you could largely take work that's been produced in another developed country and implement it straight away. So that's the adoption of existing evidence. And you can do that because of similar workforces, similar patients, similar insurance systems, similar access to resources. Now, I know that that's a sweeping statement because if we talk about what happens in Sweden, you've got a language difference. But we largely know that there's the money there, there's the resources, there's a hospital bed, there's enough practitioners to deal with patients. When you look at contextualising international guidelines into a situation, say in the Philippines, we have a disconnect between what you bring in from an international developed country guideline, which gives you the efficiencies in those in the tier 1 because the evidence is already developed, but we need local activity in tier 2 and tier 3 that becomes the bridge to implementation. Otherwise, we have a sign guideline or a NICE guideline or a Swedish guideline that is fabulously written but not implementable in local environments. And then we have the increasing complexity of working here in Africa with implementing international guidelines that, again, give us the basic tier 1 information, but need more work because, as Quinette said, we've got people living with chronic HIV and chronic TB and they're suffering strokes. We're not sure that the stroke that they suffer as a sequelae of their chronic, what was a communicable disease, and they're now living with it, is the same sort of stroke as we would deal with in Sweden or Australia. So there may need to be another layer of evidence, locally produced evidence that gives us an icing, if you like, or a layering to the tier 1 information. It's only if we do that that we can end up implementing effectively local situations. So I'd like to finish with the published version of our suitcase model. Clinical practice guidelines can travel. There's no need for you to keep remaking your suitcase. You can put travel stickers on it. If you have to, you can change it into a chair. But efficiency is the name of the game. Build on what's already been developed and put it into local context by understanding what your local resources, your workforce, your education, your end-user health literacy, your end-user literacy, and make sure that the evidence that's already out there for the taking can simply be carried from one place to another and put into place with the focus on implementation, not on the focus of evidence production. Now, I notice that there's no opportunity in this symposium for questions, but I know that my colleagues would be very happy to take questions if you want to come up and ask them afterwards. So can I ask you to thank Suzanne Bernhardsen, Janine Dizon and Quinette Lowe for their insights into their local environments. Thank you.